10 years ago, a medical student asked me, what did we do before palliative care? How it seemed impossible to imagine caring for seriously ill people without palliative care. Our roots trace back to the AIDS crisis of the 1980s, when UCSF and San Francisco General embraced caring for people with this devastating illness.
And I think that really was the beginning of my palliative care journey in nursing. I get to work what I consider, the most important field of medicine, which is really trying to help patient and families understand their illness.
Every human being, their family, their caregivers, their chosen family, should be able to get the support and care they want and they need when they're facing serious illness. My job as a chaplain is really to ensure that people's inner life is included in their care. And that can look religious, it could be spiritual, it could be existential and philosophical.
We are primarily focused on the person with the disease rather than on the disease.
One example of that is a patient I took care of in the intensive care unit. And I asked her, Mary, when you look to the future, what do you hope will happen? She said, well, my daughter's getting married in 10 months in the Napa Valley. And I thought, I don't see it. And her daughter said, well, that's fine. I'll just get married right here in the ICU. There was family, friends, nurses, respiratory therapists, doctors, not a dry eye in the ICU.
The interdisciplinary team that includes social workers, chaplains, and nurses.
We see patients together often, and each of us add a different kind of piece to the puzzle.
We have primary palliative care education for learners, especially residents and medical students and other kinds of learners. And I feel like the program we have, especially around education, I think is meant to focus on symptom management, knowing that it's hard to do these other sort of developmental stages of dealing with serious illness if, you're nauseous or you're in pain. And so symptom management is our first priority, but it's not our ultimate goal.
We're lucky to have large and robust outpatient services, Cancer Center, the Symptom Management Service, and our inpatient hospice service, our newest service that provides palliative care, hospice care in the hospital for patients who are at the end of life but aren't able to go home.
The Mary Center provides support and primary education to clinicians at UCSF, as well as community-facing workshops on advanced care planning, poetic medicine, resilience for people living with serious illnesses, as well as for their caregivers.
We have our inpatient palliative care team that takes care of people in the hospitals here at UCSF, Parnassus, as well as at Mission Bay. That is our first service that was launched in 1999. Telemedicine has been just a remarkable opportunity to serve more patients. In the research that we've done, we have found that telemedicine makes it more likely for diverse patients to be able to access our services.
Seeing my grandparents get older, I want them to have access to care that is culturally appropriate to them, linguistically appropriate.
We center diversity, equity, and inclusion in every aspect of what we do. We're diversifying our workforce here in the division because we care for people from all walks of life, and it's critical in how we serve our broader San Francisco Bay Area community here.
I would say I have a lot of really exciting visions, and I think we all share them for the DPM in the next 25 years. The best parts of palliative care should continue and be integrated into all medical care. Why shouldn't all medical care be provided by an interprofessional group of people that are supporting and surrounding and creating a holding environment for people, their families, their chosen family, and their caregivers?
I'd love for our division to lead in this, to develop scalability so that we can do something for almost everybody.
In the next 25 years, palliative care becomes an everyday word.
Our work is guided by hope. The hope for comfort in the face of suffering, for healing even when a cure is impossible, and the hope to live a good life in the face of serious illness. We are excited about the future and invite your support and partnership as we build the future of palliative care for the next 25 years and beyond.
Thank you, everyone. We hope you enjoyed that. So before we dive in, just wanted to let you all know where the restrooms are. They are out the doors here to the left. On your tables, we do have the menus throughout the day, so breakfast, lunch, and our reception later today. And we also have QR codes on the table. We do have a lively day today, so you can use your phone, check out the agenda as well as our website through the QR codes on your table. As we jump into our sessions, we will have time at the end of the hour. We're going to do group sessions, so please hold your questions till the end of the hour when we have group Q&A. So now we'll dive in and bring up our chief, Dr. Steve Pantilat, to start us off.
Thank you. Before we go any further, Andrea Bordallo, just a big hand for Andrea for setting this all up. Thank you, Andrea. Wow, well, welcome. Good morning. It's great to see everybody here. I know we have people on Zoom, so welcome as well, everyone who's on Zoom and joining us from across the country, and I think maybe around the world. Great to have you with us. This symposium marks our celebration of 25 years of palliative care at UCSF. It's the last in a series of celebrations that we've done over the course of this year to mark how far we've come, how many patients we've cared for, how many students we've taught, and the research and innovation that we've been able to achieve over this time, working together to improve the lives of people with serious illness. Oh, sorry. Wow, that was... I think I'd done this before. Here we go. Okay. I want to thank and acknowledge everyone who's helped us get to this place, to this growth, to have achieved so much. First, I want to start by thanking our current members of the Division of Palliative Medicine. Could you just raise your hand, everyone who's in the division? Awesome. Yay. Fantastic. We have some people from our past, so if you've been part of the division, part of palliative care at UCSF, but you're not currently, would you raise your hands? Thank you. That's great. I want one shout out to Rod. Rod, will you stand for just a moment? Thank you. Rod Seeger, who was Director of Spiritual Care Services back in 1999, even before that, but certainly in 1999. And for many years, Rod was one of the original members of the palliative care team when we launched, part of the committee that helped launch our service and was our first chaplain with the palliative care service. So Rod, thank you for your vision in helping us to launch. It's really great that you're able to be with us. I want to thank members of our Patient Family Advisory Council who help us to make sure that the work that we do really is relevant to our patients and their families and really addresses the issues that are most important to them. I see, I want to just shout out Terry Rose, who leads our Patient Family Advisory Council. Terry, thank you. I see Jeannie Slynn in the audience. Thank you, Jeannie, member of our council. And I think there's some folks on the Zoom, but I don't, so thank you. I also want to thank our our many donors who support the work that we do and make the work of the division possible and allow for so much of the innovation. We really appreciate the support, obviously the financial support, but also just the sort of the moral support that really demonstrates that the work that we do is important not just to us, but to the people that we care for and the people in our community. And I also want to thank our foundation, our many foundation partners who over the years have really contributed tremendously to allow us to do the great work that we've been able to do over the years. The Cambia Health Foundation, the Hellman Foundation, the Gordon and Betty Moore Foundation, UniHealth Foundation, Artstone Foundation, Stupsky Foundation, the Open Society Institute, the Robert Wood Johnson Foundation, the California Healthcare Foundation have been really incredible partners with us to do this work and to grow palliative care not only here at UCSF, but really across the Bay Area, all over California, and across the country. So I wanted to take just a couple minutes to sort of set the stage about how we got here. For folks in the division, you've heard this timeline before, but I thought I just wanted to share it again to kind of set the stage and the context for where we are today. So if we look at the history of palliative care, it really is an incredibly interprofessional history. And I think if we really want to start, we can go back to 1967, St. Christopher's Hospice and Cicely Saunders. Cicely Saunders was in some ways the original interprofessional team. Cicely Saunders was a nurse, a social worker, and a physician. So she was the whole team in one human being and really set the stage for how teams might function. I think it's really appropriate to remember Cicely Saunders, and as you'll hear when I introduce our visiting professor, Irene Higginson, who is the scientific director for the Cicely Saunders Institute, or Cicely Saunders International, at King's College in London. It was nice to have that connection. In 1969, Elizabeth Kubler-Ross published On Death and Dying, which was really the first sort of public engagement around death and dying, and really was a cultural landmark in sort of how we think about the issues and really understanding what the experience is of death and dying. She did this by interviewing people with cancer, dying of cancer at the University of Chicago. In 1972, the first hospice in the United States opened in New Haven, Connecticut. Florence Wald was the dean of the School of Nursing at Yale at the time and helped to found that hospice. In 1974, Balfour Mount, a surgeon, coined the term palliative care, which is where we are today. You know, a lot of people say, oh, you need a better word for that. The problem is the word palliative care, so you should come up with a better word. A few years ago, Dawn Gross and I were presenting to our bone marrow transplant group about palliative care and about partnering, and the very first comment was that. Like, you know, your problem is your name. If you had a better name, then that would make it better. We said, okay, thank you. If you come up with a better name, we're all ears. And then I thought to myself, you know, you just changed your name to malignant hematology. So I'm not sure we're going to trust your choice of names. But nonetheless. Hospice of Marin, which is now By the Bay Health, was the second hospice in the United States, right here across the bay. And now one of our partners was opened in 1975. Mary Taverna is a nurse who started that program. And in 1981, the first case of AIDS was reported in the United States in the MMWR. And I highlight that because, as you saw in the video, I think the AIDS epidemic really was, in many ways, the start of palliative care. I think certainly for me in my career, and I think for many of us, caring for young people who were dying, where there was no cure, really nothing we could do initially to change the course of illness. And what we were doing without having a name for it was palliative care, trying to make people's quality of life as good as we could, help them make good decisions at the end of life. And it was really a dominant experience when I was here at UCSF in medical school and as a resident as well, and really a privilege to be a part of that. You know, medicine moves on, and today we rarely see someone with HIV, and if we do, that's not why we see them. We see them because they have heart failure or some other thing that you get just by being around a while. So that's a remarkable story, but really, in many ways, set the foundation for the work that we do. And when I look back, that really is where I learned palliative care without having a name for it. In 1982, the Medicare hospice benefit was signed into law by President Ronald Reagan, which really formalized a payment mechanism for hospices that were all volunteer, basically, until then. And in 1985, there were 130,000 new cases of AIDS in the United States. So while that epidemic is not over, the treatments really have completely changed that. And then in 1987, there was AZT, and then more treatments after that. So that's sort of setting the stage of what was going on around the world and across the United States. And then we can turn here to palliative care at UCSF Health. And it was in 1999 that we launched the adult inpatient palliative care service. A group of us looked around and said, we could do better. We can do this better than is happening now. The support study had been published that demonstrated just how terrible care was for people at the end of life in American hospitals. Honestly, it was a pretty low bar. I mean, care was so bad, there was nowhere to go but up. And a group of us got together and said, we're going to focus on making this better. And we did. We launched Comfort Care Suites up on 12 Long, rooms, creating an environment for people who are at the end of life to be able to have a more peaceful environment. A couple of things we did. We turned off the intercom in the room so it wouldn't be loud when they were announcing something on the floor. We hid the medical equipment behind cabinets. Some of the things that you'll find maybe in any hospital room today, if you go to Mission Bay, those rooms are nicer than our Comfort Care Suites were then, but they were an incredible advance. And I think poignantly, they were modeled on our birthing suites. So we were on the 12th floor. The birthing suites used to be back in the day on the 15th floor of Long Hospital. And they had rooms at the end of the hall with this beautiful view that created a more home-like setting. And we thought, if we can do that for the beginning of life, because it's an important time, let's do the same thing at the end of life for people who have to be in the hospital. In 2000, pediatric palliative care programs started to care for children with life-limiting and serious illness. In 2004, we launched Palliative Care Leadership Center to work with teams from institutions across the country to help them develop palliative care. You'll notice that that's only 5 years after we started, and so there was some hubris in there to think that we actually knew what we were doing. But Mike and I had a lot of confidence, maybe more than we deserved, but there we were teaching other people to do this. We've now worked with teams from over 300 institutions across the United States, and just 2 weeks ago had a PCLC visit with another team just down the road at El Camino Hospital to help them build their outpatient palliative care. So there's still a need out there to build palliative care services. Despite all the evidence, there are still people not getting palliative care and institutions that still need to build these services, and our expertise is really critical in helping them to bring this about. And I think also really speaks to, the ethos that we have here, which is we're not just trying to make care better for people here at UCSF, but we want to take our expertise and share it and really disseminate it across the country and around the world to make care better everywhere for people with serious illness. 2005, Mike Grable launched the Symptom Management Service to take care of people at the cancer center outside the hospital who need palliative care, where there is a tremendous need, one of the first services of its kind in the country and now one of the largest. In 2007, we won a Circle of Life Award from the American Hospital Association, reflecting excellence of palliative care. 2009, we launched the Palliative Care Quality Network to improve care by the standard collection of data from patients to improve care and to develop collaborative quality improvement activities. In 2010, we started our fellowship. And hard to believe that before that, there was no fellowship. Students would ask, or residents would ask, well, how do I become a palliative care doctor? I said, I don't know. There's not really a path for doing that. I guess you just do the work. And now we have really incredible, amazing fellows year after year, our future colleagues who join us, who come here to learn palliative care, who teach us so much about what they know and create a really incredible environment. So I see, this is like the fellow table I see right here. The fellows decide to sit together. Yay, our fellows. And I want to thank Carly Zapata, our fellowship director, for her leadership. Thank you, Carly. And Hedia Matenrad. Hedia, I don't know if you're watching. Oh, there you are. I thought you were still away. Yay, Hedia, you're here. That's great. I didn't see you walk in. Our associate program director. That's great. Welcome back. I'm so glad you're here. 2012. The Mount Zion Mission Bay Palliative Care Service started when there was an inpatient service at Mount Zion is where it started initially, and then has moved over to Mission Bay with the opening of that hospital. In 2014, we went to Heart and Soul, our second inpatient service here at Parnassus. Okay, I'm just going to say, I really like those names. I'm just going to say it. I thought that was super clever. It's not after the song, it's just after your heart and your soul. Although it's been hard to come up with a third name, so if you can think of a really good third name for a team other than Mission Bay, that would be great. 2015, the UCSF Hospice by the Bay affiliation happened, and now we have an affiliated partner, hospice partner that helped us to develop our general inpatient, our inpatient hospice service. 2017, Carr Bischoff launched our outpatient palliative care service. It's hard to believe that 7 years ago, we did not have outpatient palliative care for people with any illness other than cancer. And it's just hard to believe. And an incredible OPCS team to join our other incredible teams that now makes it possible for people with any type of illness to receive palliative care at UCSF. And I mentioned this in the video, this student who said, you know, what did you do before palliative care? And that's how I just think about that. What did we do for people with Parkinson's and interstitial lung disease? It also reminds us that this all happened because of hard work that people do, by having a vision about how care can be better. And I think one of the great gifts of UCSF is the opportunity to take your idea, to take your vision, and to make it real, and to change care for the better for people. And that's been one of the great opportunities of being here at UCSF. I think that's one of the great values of being here, is the environment of entrepreneurship, the environment of curiosity, of being able to take your ideas and implement them into something real that makes care better for patients, and to work in an environment that really does care about that. 2018, we launched the Division of Palliative Medicine. We'll talk more about that in a moment. Pediatric Hospice and Palliative Medicine Fellowship started. There are not a lot of those, and I'm really proud that we have a pediatric fellowship program here. And we received a Joint Commission Advanced Certification in Palliative Care, joining just a small group of programs around the country that have that level of certification. 2021, we launched PCQC. PCQN evolved into PCQC. We started our inpatient hospice service in the middle of a pandemic. We launched a new service. We created a partnership with the San Francisco Center for Jewish Living, what we know as the Jewish Home, to develop an inpatient, palliative care consult service there that is now run by Ann Kinderman. And the Pediatric Palliative Care Clinic started. So lots of development. In 2022, the Pediatric Palliative Care Group became a division within the Department of Pediatrics. And here we are, 2024, 25 years of palliative care at UCSF. Really a remarkable journey to get here. I'm going to give us all just a round of applause for getting here. And today, we are celebrating how far we've come, but really with a look to the future. We're going to hear about really incredible innovations and programs in all of our core missions, in clinical innovation, research, diversity, equity, and inclusion, education, work that's going on today that is going to change care and improve care for people with serious illness well into the future. And that's really the most exciting part, is not so much where we've been, but really where we're going and the opportunity to go there together, which is really a great privilege. So I'm delighted that you're here. Wonderful that you're joining us today, and we have a really exciting day ahead. I'm going to now introduce Bob Wachter to say a few words. Bob is our chair of the Department of Medicine. Bob is also a dear friend. When I was a third-year medical student here at UCSF, Bob was my chief resident. I learned about antibiotics for pneumonia from Bob. It was a great talk. There were 4 antibiotics, so don't, before you get too excited. Now there's like 1,000, but it was nonetheless a great talk. Bob is really a visionary, truly a visionary, someone who can really see trends and see the future and invest in it. Famously, Bob helped coin the term hospitalist and developed the field of hospital medicine. Bob was there at the early days of the AIDS epidemic and the AIDS conference that was here in San Francisco, and he led that early in his career. He's written about errors in medicine, about digital transformation in medicine, and I think most importantly as it relates to today, really created an environment where you could take your idea and run with it. And when I was an early faculty member here, I remember I interviewed with you, Bob, for a job. And Bob said, "So what do you want to do with your career?" I said, "You know, Bob, I just want to make care better for people. I just think there's so many opportunities to make care better." Bob's like, "That, all right, that's good, that's good." And I remember I walked out of your office on the 9th floor, and I was walking to the elevator, and I thought, that is the worst answer I've ever heard. That is so terrible. I mean, that's no specificity. I mean, it's just like so, I don't know, general. But it turns out I was right. That's exactly what I wanted to do, and that's what I've done, and that's what we've done together. And Bob, I really, I thank you for creating an environment where entrepreneurship and ideas and vision were really valued, and including in 2018 when you became chair, when you made the decision to create a division of palliative medicine, which I think you get all the credit for making that decision and just how wonderful it's turned out. So thank you for all your support over the years, and thanks for being here.
Wow, what a joy to be here. Thank you, Steve. I still give the same talk about the 4 antibiotics, and the residents look, "Don't you realize there are about 70 more?" And no, this is a really good talk. Steve liked it. So it's really a joy and an honor to be here. I actually tell the story about Steve a fair amount when I give the orientation talk to new faculty at UCSF. And Steve once said to me, I don't know if you remember this, but he came to my office at one point. He's a fairly junior faculty member. He said, "I think I get it. I'm an individual entrepreneur, and UCSF lets me use its letterhead." And I said, "Yes, sort of." But what's beautiful about it is it's entrepreneurialism. Here we are in Silicon Valley. It's entrepreneurialism, not in the service of raising your fund and making $1 billion. It's entrepreneurialism in the service of doing good. And that is precisely what has happened, and truly remarkable to see what has happened over the course of 25 years. Really, this was an idea that seemed like a great idea, but a lot of steps between that and making it real, and you have clearly made it very, very real. The story of the division really was when I became chair. What had happened, as often happens in trends, is they begin organically. They begin around individuals and circumstances and funding, and very opportunistic. And what had happened in palliative care was that it happened on the inpatient side, starting in 25 years ago, as Steve said. And so where did that live? It lived in my old division, in the Division of Hospital Medicine, which, by the way, was only invented 3 years before that. So that was a new thing, that there was this thing called hospitalists. And so inpatient palliative care was embedded in the Division of Hospital Medicine. Outpatient palliative care, as Steve said, was really only in cancer, and Mike really led that through his vision, and was growing increasingly robust, and being, I think, in part or large part because Mike lived in the Division of General Internal Medicine. That's where that lived. And then there was home-based palliative care, and it was growing as well, and kind of lived in geriatrics. And so that was fine for a while when we had faculty who said, I only want to take care of sick people in hospitals, or I want to do home care. But then we had these odd people who said, I want to do palliative care, and I want to take care of people in the outpatient setting and in the inpatient setting. And they said, what division do I live in? And I said, I don't know. That's a really good question. We don't have a solution for that. One of the things I've learned in leadership roles is that your organizational structure that might have made sense 10 or 20 years ago probably doesn't make sense today because stuff happens. And anything that's really been static for 20 years, I learned this from Lee Goldman, who was my mentor in leadership. Anything that was perfect 20 years ago probably isn't right today. And yet the power of inertia is really very strong. It's hard to do organizational change. You get pushback for all sorts of reasons. But it became clear to me, and it was really driven by these young faculty members who were trying to figure out, where do I live? And it was obvious that the organizational structure wasn't right. And so it took a little bit of, I still have a few wounds, but it took a little bit of push and shove and cajoling and change management. But it was sort of obvious to me that this should be a division, and I was partly guided by my experience with hospital medicine, which in its first 10 or 15 years also wasn't a division, was the hospitalist group that Steve joined when he joined the faculty. And that was fine, and I had all the control and authority and the budget and everything I needed to do my job. But when Talmadge King became chair, Talmadge said, and we had this group of 50 faculty, and Talmadge says, why isn't this a division? And I said, I don't know, it probably should be. And so that is how the Division of Hospital Medicine formed. And part of my epiphany from that was I didn't think it was going to be that big a deal, but it turned out to be a massively big deal to sort of have this identity, to be in control of your destiny. And so my decision to create this division was based in part, I knew that there would be something very magical and special that would happen when it was its own thing, and that has clearly been true. You might say it was inevitable that this would succeed. In some ways, the need is so obvious, and there's a little bit of if you build it, they will come thinking. I sort of think that's wrong and kind of BS. You can build it, and they will not come unless you have spectacular leadership. I absolutely firmly believe that. And as I look around the room, and I know the people in this group, what is spectacular about it, not only is your mission and what you do every day, but Steve has built an enterprise and a culture where fantastic people are drawn to it and want to come and want to stay and tell their friends that this is a great thing to do and a great place to be. And for that, that doesn't just happen, and that's not, you don't do that through an org chart, you don't do that through a budget, you don't do that through a philosophy, you actually do that through leadership. So Steve, thank you for everything you've done. It's really been remarkable to watch, and very proud of it. What have I learned from the division? Sort of seems obvious now, but really these were all new ideas. The idea of teamwork, we talked about it a lot, but I've never seen it incarnated in a way that I see in this division. I mean, people give it lip service all the time, and interprofessional this and that, and teams and all that, but the governing philosophy of this division and of the people in it, that there really aren't hierarchies. There are this amazing group of people who bring their separate talents and training and focus to the table, and it is this amazing sort of chemical reaction that happens when all of them are invested in learning from each other, and the leader is whoever is the leader, the appropriate leader for that thing in that moment. That is such a foreign concept that violates everything I learned during medical school about the hierarchy and the captain of the ship and all this stuff. We talk about it a lot, but I think not only do you all do it every day, but you have taught all the rest of us about that and how important it is to get that right. So I really do thank you and celebrate all of you for doing that. It's really inspiring. The second thing I learned is I kind of learned this. We do these things called Net Promoter Scores now, where we give surveys out, it seems like about every 5 minutes, to find out how happy people are and how invested they are in their work. And so I've got a now very large department with 1,000 faculty and 45 divisions. And the first one that came back, and I looked at how all the divisions did, positive 100 is the best possible score, negative 100 is you should never ever come to work in this place, it's torture. And the department sort of does 0 to 5, plus 5 generally, and palliative care was, I don't know, plus 40 or something like that. Actually, by a fair amount, the top-rated division in terms of people's joy in coming to work. And when you tell people that, they look at you like, no, that's crazy. You mean, positive 40, it must have been minus 40. You missed the minus sign. No, it is the group of people, at least on our faculty, who are most likely to say, this is a fantastic place to work, and I would tell my friends that they should work here, and I would tell my patients they should get care here. I'm no longer surprised by that. It's certainly not because they're well paid, because in the hierarchy of medical world, they're not. It is truly about the joy that comes from purpose, from doing something that's meaningful, where you know you're making a difference in the lives of patients, of families, of trainees. It's really spectacular. So I didn't know that until I sort of had a vague sense that purpose is important, but it becomes blaringly obvious when you see that. And one other thing I'll mention that I learned, also not really a surprise, but when COVID hit and everybody in the division sort of ran to the fire and said, how can we help folks in New York? That was also incredibly inspiring. And again, in retrospect, not surprising at all, because that's the nature of the group. It's a real great pleasure to have a little bit of pride of ownership in this and reflect on the things that I have learned from you, Steve, and from the division over the course of the years. And I too, people sometimes say to me, I can't imagine a day before there were hospitalists, because as Steve mentioned, I coined that term and kind of helped start that movement. And the answer is, yeah, I can get that, because I've got 1,000 faculty in the Department of Medicine, about 200 of them are hospitalists now. It's remarkable how big it has become, 60,000 hospitalists nationally. And yet I sort of can imagine a day before hospitalists. So you just had a different doctor who was the inpatient doctor, and I think that I sort of believe strongly that having hospitalists in those roles has been helpful for the system. But it doesn't cause my brain to explode thinking about a day before there were hospitalists. When I think about a day before there was palliative care, I don't get it. I actually do not get what we were doing. I think back about some of the care that I gave to patients who were at the end stages of life and dealing with their family, and I'm a little bit ashamed by it, because I'm pretty sure what I did was unethical and certainly was not meeting the needs of patients and their family. And I don't think I was alone. I think that was sort of the dominant way. We did not know what we did not know. We did not know how different things could be. And now, when I see a medical student or a resident and they say, how did you possibly do this before palliative care? The answer is, I actually have no idea. But I'm glad you folks are here. So thank you. Thanks for allowing me to be a part of this celebration. Appreciate it.
Thank you, Bob. And thanks for your vision around COVID. I have many friends around COVID, they're like, oh, I get all my information on Twitter from Bob Wachter around COVID. Do you know that guy? Do you know that guy Wachter? I'm like, yeah, I know him. You think his COVID advice is good. You should hear his antibiotic talk. At the break, yeah.